So now I invite the panelists here. So all the speakers are there. So for panel discussion, we have Sojata Majumdar is there. Dr. Subhasis Rai Chaudhary is there. Yes. Subhasis, you want to add something on this, any of these four topics?
Excellent deliberations and very difficult to finish on time also, so diverse topics. One comment regarding Berostim to Ishita is that all of these newer FDA approved devices that are coming in, please remember that these are coming in due to accelerated FDA approval mechanisms. So if you look at the trials, none of them are placebo controlled. And that's the way it has been designed, that they will not be placebo controlled. All the endpoints that if you look at, they're not hard endpoints. They're all soft endpoints like 6-minute walk test and, quality of scored improvement, quality of life scored improvements. And with an idea that once they come into the market, they are going to undergo post-market analysis, all Bedostim, CCM and everything. So yes, we are very interested in these, but I think we should always be taking them with a pinch of salt. I had a question to Imran actually. What would be your message regarding the use of vasoreactive test, the practical message regarding the use of vasoreactive test in a patient of pulmonary hypertension? Would you ask us to do it or not do it?
So I think vasoreactive test is ideal for idiopathic pulmonary arterial hypertension, some with drug-induced toxins also, not much with left heart failure diseases. That's the first message. Suppose you're planning a heart transplant. In those conditions, when you're approaching that, you can do that. Now, vasoreactive testing, as you say, there are 2 to 3 substances can be used. As we know, inhaled nitric oxide is there, iloprost can be used. Now, the definition of vasoreactivity is that once you're applying the substance, they have different doses, different timing for those substances. If the mean pulmonary arterial pressure should come by less than 10 millimeter mercury, and overall the total pressure, the mean should be below 40. So suppose our pressure is 50, mean pulmonary arterial pressure of a patient is 50, we do a vasoreactive testing, it comes to 35. So there's a decrease of 15 and it has come, the total level has come below 40. So that indicates that it's vasoreactive. So it not only decreases by more than 10, it should go below 40, the mean pulmonary arterial pressure. That's one thing. And if the patient is vasoreactive, that's almost like 5 to 10% of pulmonary arterial hypertension patients. In that case, high dose amlodipine, nifedipine, even diltiazem can be used. So that can be used. You can start with a 5 milligram dose, but you can go to 20 milligrams of amlodipine. So, or felodipine. The amlodipine, felodipine are the same doses. And of course, that can be used. So any other further thing you want to know in this regard? Because if they are responding, it's quite good response. Then you don't need to go for these other molecules,
The only problem is you have very small subsets of patients who will be...
Right, sir. Right.
That is a
very
problem.
Small subset. Only in idiopathic, it's 5 to 10%. And otherwise, you can't do the vasoreactors in other cases. Right.
Ishita, I have a query, whether patient who was on CRT, and why don't you use this device? Can they be useful also?
Yes, there has been few patients in which if there is a CRT failure, then you can use, it was an indication which was given in this, you can use this Barostim device if it is a CRT failure, but not as a first line procedure.
And you believe that if you have a heart rate variability has been studied, if the heart rate variability is low, then probably this device will work better. Do you believe this?
No, it will not work.
Why not that?
If the heart rate variability is high.
No, if heart rate variability is not there, it means patient has sympathetic system overactivity is there, vagal activity is less. So probably they will be responding better.
Yes.
Dr. Nagori is there? No. It's not there. And what about this thoracic impedance measurement? And we have some device that has come. You can just have from outside, you can just measure the thoracic impedance and have some assessment of the...
So we do, sir. So like this patient I spoke to you about. So she has the Gallant device manufactured by Abbott. Abbott comes with a proprietary algorithm called CoreView, impedance monitoring, whereby you can actually pick up early extra long water and you can actually prescribe diuretics. But the problem with this is that, like all devices, it needs to establish a baseline first. So ideally, these devices, it has to be switched on when this patient is actually absolutely decongested to understand what the baseline value is like, and then only you can switch this on and send the patient back. So what happens is, when there is increased bioimpedance because of edema in the lungs, so the machine starts vibrating, which
That is, you are talking about this CRT device. I'm
ICD
saying
device, sir.
there is a pad that you can
Yes.
place on the thorax from the back and front, and
Yes,
you
sir.
can
Yes,
measure
sir.
the impedance.
So
In the
so
non-invasive, you can.
I know, sir, but most of the trials, I think they're not very
Yeah,
sensitive. They're not very
yeah,
sensitive for picking up. That's what I understand. I mean,
yeah,
they're not as good as, let's say, the CardioMEMS device, which actually gives you PA pressures.
yeah, yeah. So your role is to just prevent hospitalization. That is very, very important. And for patients who are not responding to heart failure management, we have some role of this carotid stimulation. And imaging is a very important part where you have to use all the modalities and most of the patients to have the best diagnosis of the patient. Sometimes we miss amyloidosis, we miss sarcoidosis. So this proper imaging has to be there if there is a iota of any suspicion. And even coronary angiogram in some patients, we are just, some of the patients are left as DCM, non-ischemic, but if you do imaging, you can find by CT angiography or by invasive, you can find there is a coronary artery disease. So imaging is a must. And Imran's problem was you have a RB dysfunction with pulmonary hypertension. It's a very difficult time once you have to start treating. Once the RB is dilated and you have a significant pulmonary hypertension, and the management becomes very, very difficult. We don't have a very definite guidelines for the management of this type of heart failure patients.
And
So we have,
especially if you have internet issues, then the management becomes even more difficult, sir.
so we had a wonderful discussion. Thank you everybody to join, and we learned a lot from the discussions. Thank you all.
Thank you, sir.
Thank you, sir. Thank you.
Thank you, everybody. And it is time that we will break for the lunch session. But I would request all the participants, panelists, chairpersons, speakers to kindly visit the exhibition area. Do have a browse in the exhibition area of the conference. And we will all be back on time sharp at 2 o'clock at the next session to begin with. Till then, enjoy your Sunday lunch and happy learning once again. We are breaking for the lunch right now, but please make sure that you're visiting the exhibition area. Thank you.
What's in the menu?
The menus are on your own choice, on your own platter, sir. We will hold on to the next meet physically,
Right.
and I'm sure the organizers will treat us double that time.
Thank
Thank
you.
you. Thank you.
Thank you, sir.
Thank you.